and thank you very much for the kind invitation. As I was saying, tumors occurring within the first 28 days of life, that is our definition for a neonatal tumor. They are relatively uncommon, 1 in 10,000 live births, and they appear to be mainly sporadic mesenchymal or embryonic origin. Approximately 25% of these tumors arise from soft tissue, and more than 60% are benign. Our frequency, the experience we've had over 38 years in Glasgow, is as follows. We've seen mainly teratomas and neuroblastomas. They form about 50–60% of these neonatal tumors. And then a whole variety of soft tissue tumors, central nervous system, leukemia, renal tumors, hepatic tumors, and thoracic tumors. The common features of these neonatal tumors are that many of the malignant neonatal tumors are histologically unique in that they mimic embryological development, they exhibit features of organogenesis specific to the site of the tumor of origin, and they have more primitive embryonal rather than pleomorphic anaplastic appearances on microscopy. Of course, malignant epithelial tumors are very, very rare in our experience. Now, this is an embryogenesis diagram showing how a lot of the germ cell tumors arise as a result of failure of differentiation. And you can see this beautiful diagram prepared by Sri here, how embryonal carcinomas may arise from choriocarcinomas, yolk sac tumors, and of course, the common teratoma, which arises from the epiblast with a trilaminar germ cell layer. The biological behavior we understand is that these neonatal tumors behave differently from childhood cancers. The benign tumors can transform to become malignant. The histologically malignant tumors behave like benign tumors, and we can get life-threatening benign tumors depending on the site and where they arise from. So we've got, for instance, 15% of neonatal tumors are associated with congenital abnormalities, especially chromosomal defects 13, 18, and 21. Excuse me. The genetic risk factors are, we're familiar, we've already heard about Li-Fraumeni with hepatoblastoma, the P53 mutations, the chromosomal aberrations giving rise to retinoblastoma and Wilms tumor. The environmental risks we know that could be associated with the development of these tumors are radiation in the perinatal period, drugs taken in pregnancy, whether recreational or therapeutic, maternal infection and cancer, and of course, carcinogens. Clinical presentation, well, since most of them arise from the sacrococcygeal region, even though they are rare, it is a mass in that area. We've seen abdominal masses, commonly neuroblastoma and occasionally renal, thoracic masses where teratomas usually occur, and unusual soft tissue masses that do not respond to conventional treatment. One should be very well aware that they could be a sarcoma and can progress very rapidly in the neonatal period. And of course, the syndromes that we know are associated and need careful monitoring to pick up tumors that might arise later on. Most of the tumors present in the first week of life, about 50% in our experience presented then, and another 30% in the second week, and then thereafter when they are picked up clinically. Investigations are very similar to what we would do in older children. However, the imaging has made an enormous difference now by ultrasound and by fetal MRI scan to pick up clear definition of these tumors and prepare the team for when the baby is delivered. Of course, we've got CT scans, isotope scans. The tumor markers, well, they're the familiar ones like alpha-fetoprotein for the teratomas and liver tumors, the catecholamines for neuroblastoma, HCG, CEA, and renin. Of course, the final diagnosis in these neonatal tumors is done by tissue biopsy, and very often a fine needle aspiration, ultrasound guided, is very helpful and produces most results. but they also help us with the cytogenetics, with the N-MYC-oncogene copies, which we've already heard already. If they are increased, then it becomes a very different prognosis. Histological grading antibodies also that are being picked up to determine types of sarcomas, which may be difficult to find. Now, calculations are based on protocols for all the children. So very few protocols exist in the neonatal period. And errors, of course, can occur in calculations of drug dosages and radiotherapy. We hear about tumor dosages being halved or quartered, but it is, not really very accurate science. The drug dosages, however, are based on the weight of a baby rather than the surface area. That is one important difference. Now, we know that most neonatal organs and systems continue to mature in the first 1,000 days of life. So therefore, neonates are vulnerable to surgery more than older children, to chemotherapy and to radiotherapy. What are these surgical risks? We've already heard from my friend and colleague about the surgical risks and the complications that can arise, and these are more prevalent in the neonatal period. Of course, fetal surgery is the first one to talk about, where prematurity is a big issue if one's going to induce an early labor. And of course, the next question you should ask, is surgery needed in all cases? And I'm going to show you some examples we've had in our experience. The chemotherapy risks, well, the standard neurotoxicity for vincristine, hepatotoxicity for actinomycin D, renal autotoxicity for cisplatinum. Radiotherapy risks, well, overdosage can lead to developmental arrest, skeletal scoliosis, cognitive and mental impairment, very important if one is irradiating a baby, and secondary tumors like breast and thyroid, and of course, insufficiency as a result of the toxic side effects of these therapeutic agents. Now, what I'm going to show you here is our experience over 38 years in Glasgow, showing our neonatal tumor experience. And you can see we've had 115 cases in all. There are 55 teratomas and 17 neuroblastomas. And of course, the rest are other types of tumors I've mentioned already. Can I mention that the therapy involves maybe a 20-year period, which was historical, and then the last 20 years being more conventional therapy in these cases. First of all, the teratomas. We've had 55 teratomas, 47 were sacrococcygeal, and a variety of abdominal, cervical, thoracic, and one orbital. Here you can see the standard sacrococcygeal tumor we're dealing with. Another orbital benign teratoma was treated by surgery alone, and no further treatment was needed here. The neuroblastomas, we've had 17 neonatal neuroblastomas, and there were 8 that were 4S. And I'm going to show you now one of our babies at 25 days of life presenting with a large abdominal mass. And there was gross hepatomegaly and multinodular appearance on ultrasound at 25 weeks of the liver. The catecholamines were raised. As you can see, the other tumor markers were not. And here we can see that the MRI scan performed on day 30 showed a multinodular liver with encasement of the aorta and the celiac plexus. A fine needle aspiration ultrasound-guided tumor biopsy was done, and it identified the small round blue cells consistent with an undifferentiated neuroblastoma. Excuse me. There was clinical deterioration here in the patient, and in fact, she needed to be ventilated. What was the further management? Well, we decided to start the baby on carboplatin and then eventually etoposide with no improvement. Surgical options had to be considered because of the deterioration, we considered ventral hernia, a silastic patch, liver resection to relieve the compartment syndrome, which was going to kill the baby. Radiotherapy, however, was given, a single fraction, and there was a change in the clinical picture following that. The baby was then extubated, on day 62. And then you can see at 18 months of age, an MRI scan showing no focal pathology there. So in summary, our experience with neonatal neuroblastoma accounts for more than 20% of these neonatal cancers. Observation is adequate for spontaneous regression, and it is safe provided there are no life-threatening symptoms like compartment syndrome, that the NMIC amplification is not increased, and there are no segmental chromosomal abnormalities. However, if NMIC amplification is present, that mandates a high-risk protocol. Excuse me. Our experience with renal tumors has been entirely congenital mesoblastic nephromas. You can see one diagnosed antenatally on this scan. And here the pathology shows you these fibrous masses pushing the kidney aside, and surgery is all that is needed in this case. Our experience with soft tissue tumors has been a variety of soft tissue tumors. I won't go through them all. I'll show you one neonate that was born to a mother who had been on warfarin for blood clots, and the baby presented with what looked like a hematoma of the left knee. And after 2 weeks, this did not behave entirely normally. It grew. It turned out to be a sarcoma on biopsy. And you can see within 3 weeks, we had inguinal lymph nodes there. Unfortunately, this baby succumbed to a very aggressive sarcoma. We had 9 liver tumors, 7 hemangioendothelioma, a mesenchymal hamartoma, and a hepatoblastoma. This 20-week gestation scan shows a vascular mass in the left lobe of the liver. There was also polyhydramnios, macrosomia, abdominal distension, a large heart, and an edematous placenta. And here you can see the antenatal MRI showing increased vascularity in the liver. So the baby was born by emergency section and intubated after 5 minutes due to very poor respiratory efforts. Within 4 days, an MRI scan showed a lobulated hypervascular mass arising from the left lobe of the liver with shunting, and the medical options considered here were prednisolone, alpha interferon 2B, and prednisolone and propranolol. However, there was rapid deterioration with ascites, and there was congestive cardiac failure, which was not responding to beta blockers or steroids. Here you can see the venous phase showing increased shunting with a hugely dilated left hepatic vein. So a left hepatic artery ligation was performed on day 47, and follow-up showed improvement. A true cut biopsy was done at the age of 1 year, and there was a small residual calcified lesion present. And currently the baby is not on any cardiac medication. So in summary, infantile hepatic hemangioendothelioma, which are large, can cause up to 90% mortality if untreated. There are medical managements available like beta blockers, steroids, and interferon. And further management, I think nowadays with the skills that we have seen already, interventional radiology is a must and should be considered the first option. Following that, selective hepatic artery ligation. And of course, if it is extensive, involving a lot of the liver, then one has to think about liver transplantation. There have been a few cases reported of malignant transformation. I'm not quite sure whether this is credible or not. We had a group of miscellaneous tumors, which are seen in most institutions. And finally, I would like to show you a benign tumor, which was picked up at 34 weeks gestation. And it's a cystic mass on the right side of the neck, showing possibly a query cystic hygroma. An emergency section was performed for fetal distress, and a large cervicofacial tumor and a cleft palate was seen. The baby was intubated, then taken to theater, had a biopsy and a tracheostomy, and tumor markers were performed, which were within the normal range. So the scan here shows a large multiloculated cystic lesion arising from the cheek, extending to the mouth, lip, and lower eyelid. Surgical excision was done on day 8, and further excision because of residual tumor was done on day 20. And here we've got the child at 12 months and 2 years of age, after having had extensive plastic and faciomandibular surgery. So in conclusion, Mr. Chairman, neonatal tumors are very rare. A national register is good practice to share the experience with other people. Sacrococcygeal teratoma, neuroblastoma are the commonest tumors seen, and treatment is very different from childhood tumors because of the nature of these tumors. Early diagnosis is mandatory. Our experience from our historical cases is that overtreatment is dangerous and sometimes unnecessary and contributes to the morbidity and death of some of these babies. And of course, survey of all at-risk groups is essential. Thank you very much indeed for listening.